And let's go with those questions for the acute coronary syndrome. The first one is going to be an 86-year-old woman with a history of hypertension but without prior coronary history is transferred following TPA administration for an inferior STEMI. She's pain-free and has resolution of her ST segment elevation. 12 hours later, she develops chest pain and dyspnea. On exam, she's in moderate distress, laying supine with a new systolic thrill present. Laying supine with a new systolic thrill present. Laying supine. Okay. There's a large V wave on the wedge pressure. Which of the following is the most likely etiology? Free wall rupture, ventricular septal defect, RV infarct, papillary muscle rupture, complete heart block. Okay, let's see. Okay, remember, she's laying supine. Jeff will talk about this in just a minute. Number 2, 72-year-old man presents within 2 hours of crushing chest pain and diaphoresis. He's got an inferior STEMI. He's taken to the cath lab where he's got a proximal right coronary artery with successful revascularization. Taken to the CCU for further care. In the CCU, his vital signs are a heart rate of 120, blood pressure 80. Physical examination, the venous pressure is elevated with X and Y descents present. Lungs are clear. There's a third heart sound audible. Next step is fluid, furosemide, emergency echo, cardiac surgery consultation, IV dobutamine. Oh, this is good, isn't it? Okay, so this is actually quite dependent on your physical examination, and Dr. Geske will go over that in just a minute here. Okay, number 3, with regard to papillary muscle rupture, which of the following is correct? Anterolateral papillary muscle most commonly involved. IV phenylephrine should be used for hypotension. A harsh pansystolic murmur is typically present. Early surgical intervention is the management of choice. Diabetes is a risk factor. What do you think? Early surgical intervention. All right, so what we're going to do now is we're going to turn to mechanical complications of myocardial infarction, something that we see occasionally, but when you see, you really have to know what to do with, and a very common thing that's asked with testing. So Dr. Jeff Geske, who was introduced earlier as one of our approachable people, but has done a lot of work in putting this course together. One of our new emerging educators came on staff within the past year, does echocardiography, hypertrophic cardiomyopathy, valvular heart disease, and actually, if you look him up, has had some quite outstanding publications in the area of hemodynamics, is going to now take on the task of talking about the mechanical complications of myocardial infarction. Jeff?
Well, thank you very much for the kind introduction, Dr. Nishimura. It's an honor to speak here, and congratulations to both Dr. Nishimura and Dr. Aman for a fantastic course and for the 20th anniversary. I have no disclosures for this talk other than the fact that I have a little bit of an odd sense of humor, so I have to put up with that. Our learning objectives for today are really threefold. 1, to recognize and diagnose mechanical complications of myocardial infarction. 2, to select appropriate management for those patients. And then 3, to review post-infarction conduction abnormalities and how to approach those. I would just say, I know that we're getting towards the end of the day and I'm the only person standing between you and dinner, but this was a really high-yield section for my board examination, which occurred not that long ago, so it's worthwhile to pay attention. It's really important to have a schema to approach complications because you'll see there's quite a few of them. I'd really like to give Dr. Anna Vakar, who just was up here for quite a while, a lot of credit for helping to put together this framework. I like to classify complications as either mechanical, electrical, or non-myocardial, which really encompasses both pericardial and then the thromboembolic and bleeding complications as well. When we look at the mechanical portion of this, we can further divide it into those patients who have an unruptured mechanical complication, such as profound left ventricular failure, right ventricular infarction, LV aneurysm, ischemic mitral regurgitation, and dynamic outflow obstruction, or the rupture complications, which can be split into papillary muscle rupture, VSD, and free wall rupture, which can be further divided into frank rupture or contained rupture. There's a lot of things, and we're going to start off by tackling the unruptured complication and dive into profound left ventricular failure. As we talk about this, it's important that we're all on the same page, that we have the same definition. And cardiogenic shock is decreased cardiac output in the setting of adequate intravascular volume with signs of reduced perfusion. This translates to hemodynamics of a systolic blood pressure that's less than 90 and sustained, typically 30 minutes, pulmonary capillary wedge pressure that's greater than 15 millimeters of mercury, and a cardiac index of less than 2.2. When you think about causes of cardiogenic shock, there's a number, but within acute myocardial infarction, we're typically referring to extensive infarction. That is greater than 40% of the left ventricular myocardium that has become dyskinetic or hypokinetic or akinetic, contributing to the hemodynamics. You'll see that each of the other complications that we will talk about today can also contribute. Right ventricular infarction, rupture syndromes, and arrhythmias. And of course, there can be non-myocardial infarction complications that can lead to cardiogenic shock, and those are really addressed in other portions of the course. When we think about profound left ventricular failure, we know that there are a number of identified risk factors. Elderly patients, diabetics, those with anterior infarction, prior myocardial infarction, or extensive coronary disease, 3-vessel or left main disease. And it's also been found that early use of beta blockers in large infarcts can result in profound left ventricular failure. And that brings us to our first key trial. I told you I had a bad sense of humor. But for each of the key trials that we discuss in the talk, we'll try and discuss the question that's asked and then a take-home point. And then for each of those, or for some of the trials, we'll dive into the trial a bit more, but I really want to give you the bottom line. What do I need to know from that trial? So the COMMIT trial asked, what does use of beta blockers in the setting of acute MI do? And specifically, how about high-dose IV beta blockers? This was a huge trial, greater than 45,000 patients with acute myocardial infarction who were randomized to either metoprolol or placebo. And when you look at the dose of metoprolol that was given, this was hefty dose. This is 5 milligrams given IV every 2 to 3 minutes until 15 milligrams, and then 50 milligrams IV every 6 hours. So during the first day, you'd get greater than 200 milligrams. And what they saw with this is that metoprolol resulted in reduction in rates of reinfarction and reduced episodes of ventricular fibrillation. But with all that beta blocker on board, patients were more likely to develop cardiogenic shock. So therefore, the take-home point is going to be to avoid high-dose beta blockers in the setting of acute myocardial infarction, particularly large infarcts. And this profound left ventricular failure can be a fatal complication, so that's a really important thing to recognize. Even though it only occurs in about 10% of myocardial infarcts, it accounts for 70 to 80% of the mortality. So what's the role for emergency revascularization? We've just learned a lot about this from Drs. Barsness, Anna Vekar, and Askew. What is the role for emergency revascularization in the setting of cardiogenic shock? That's the question that was asked by the SHOCK trial. And what the SHOCK trial did is it randomized 302 patients with ST elevation myocardial infarction and cardiogenic shock into either initial medical stabilization, which did include fibrinolysis, or into emergency revascularization is about 50-50 between PCI and CABG. The SHOCK trial found that there was no mortality benefit associated with emergency revascularization when all patients were assessed at 30 days. But if you did subgroup analysis and looked at younger patients, they did have survival benefit both at 30 days and at 1 year. And if you looked at the whole trial and at further outcomes at 6 months, 1 year, and 6 years, there was mortality benefit. So this translates to the current guideline recommendations that in younger patients who experience cardiogenic shock, within the first 36 hours, early revascularization, use of PCI and CABG is indicated and recommended. And actually, it may be appropriate for the older patients as well. Recall that they had better outcomes at 6 months, 1 year, and 3 years. So our take-home point from the shock trial is that early PCI or CABG should be considered for shock, particularly if the patient is less than 75. What about intra-aortic balloon pumps? What sort of evidence is there for those within the setting of cardiogenic shock? For this, we turn to the SHOCK 2 trial. The SHOCK 2 trial took 600 patients with non-rupture causes of cardiogenic shock and randomized them to receive routine intra-aortic balloon pump or not. And there was no benefit associated with intra-aortic balloon pump at 30 days or 1 year. So the take-home there is that it's not the first-line treatment for cardiogenic shock. However, the guidelines give us some wiggle room. In patients who do not stabilize with initial pharmacotherapy, it may be reasonable to give them intra-aortic balloon pumps. And in recalcitrant, difficult cardiogenic shock, we may need to turn to our interventional colleagues and think about things like the tandem heart, percutaneous LVADs, in order to pursue further hemodynamic stabilization. Is there any role for adjunctive medical therapies to suppress inflammation in cardiogenic shock? There were some initial animal studies that were promising, looking at nitric oxide synthase inhibitors or complement inhibitors. And there were trials designed to look at this, the TRIUMPH and APEX AMI trials. We're not really going to dive into those. Both trials were actually discontinued early because they were largely negative. And this has no role in the present clinical management of cardiogenic shock. Let's now turn our attention to that of right ventricular infarction. Right ventricular infarction occurs in about 10% of infarcts and is typically more common in patients with inferior myocardial infarcts, inferior STEMIs, typically resulting from proximal right coronary artery occlusion. While long-term prognosis is good, these patients can be acutely ill. It can be challenging patients. And right ventricular infarct does raise in hospital mortality. However, if you survive, the right ventricle usually recovers fairly well. Electrocardiographically, the most sensitive features for RV infarct are 1 millimeter of ST elevation in leads V1 and V4R. And we will learn a lot more about ECG criteria from people smarter than I am tomorrow during our EP day. But here's just an example here demonstrating that classic finding in the setting of a right ventricular infarct, where we also see a dilated and grossly hypokinetic right ventricle. In right ventricular infarction, ischemia results in systolic dysfunction. So our right ventricular stroke volume goes down, our right ventricular systolic pressure goes down, blood flow through the lungs is decreased, and thus we have reduced left ventricular preload. Because of that, we have a reduced cardiac output. The right ventricle tries to compensate by dilating, by shifting along its Starling curve to increase the stroke volume. We also see diastolic dysfunction in patients with right ventricular infarction. So increased right-sided filling pressures with an associated S3, increased pericardial pressures because that right ventricle is dilating, and that can lead to kind of a tug of war between the RV and LV because there's only so much space within the pericardium acutely. These patients present with a classic triad. It's a great thing to test on: hypotension, clear lung fields, and elevated JVP. But that's not specific to RV infarction, and we saw that in the questions here. These findings can mimic other things. However, there are other exam findings that can clue you in. If your patient loses their Y descent, that can be a clue for tamponade. They might also not have an S3 at that time, which is more typically present with RV infarction. So this can help clue you in. You need to do the physical examination on patients with hypotension after acute myocardial infarction. Examination is key. The RV is not isolated from the RA. Indeed, the RA provides a prime of preload that the right ventricle desperately needs in the setting of infarct. And when you lose atrioventricular synchrony, something like atrial fibrillation or AV block, you can end up reducing your preload and further worsening your hemodynamics. Elevations in right atrial pressure can also result in a reversal of shunting at the atrial level. You can get a right to left shunt, which can result in hypoxia that is not correctable via supplemental oxygen. Treatment is prompt reperfusion, but oftentimes these patients require significant IV fluid resuscitation to maintain RV preload. Patients with RV infarction require significant IV fluid resuscitation to maintain preload. This is the primary treatment for patients who have been adequately revascularized. They may also require inotropic support, but the first line is IV fluids. You may also need to do things to maintain that AV synchrony to keep your right atrial prime. And you want to avoid things that make it harder for the RV to work, things that increase RV afterload, like hypoxia or positive end expiratory pressure ventilation. Let's next move on to left ventricular aneurysm within our unruptured mechanical complications. This occurs in less than 5% of STEMIs and is more typically associated with anterior infarcts. Thankfully, the incidence of this is decreased with timely reperfusion techniques. Here we have a cartoon that demonstrates a true left ventricular aneurysm, and I would point out that the aneurysm involves all layers of the myocardium and has a broad-based neck. Yeah, there's some groans, okay. So when you see a broad-based neck and all myocardial layers, that's a true aneurysm. And here's a cardiac MRI that demonstrates this. This is a steady-state free precession image. You can think of it as almost like an echo sort of image. And what we see here is a broad-based neck and all layers of the myocardium involved in this inferior true aneurysm. Let's talk about ischemic mitral regurgitation. What do we see in that? This occurs when you have ventricular remodeling in the setting of infarct that then tugs on the subvalvular mitral apparatus, causes tenting of the mitral leaflets and annular dilatation, resulting in mitral regurgitation. Here we see an example of this. There's akinesis of the inferior lateral wall with restriction of the posterior leaflet and anterior leaflet override, resulting in this eccentric mitral regurgitant jet. What do we do for these patients? We pursue timely reperfusion, as we do for all of these mechanical and electrical complications. Patients may also require diuresis because that acute mitral regurgitation results in pulmonary edema. And we want to pursue afterload reduction when possible, because that makes it easier for blood to leave the heart through the left ventricular outflow tract by making that pathway easier, as opposed to going retrogradely into the left atrium and pulmonary vascular bed. Patients who have a higher degree of mitral regurgitation after AMI have worse long-term survival. The last of our unruptured complications is that of dynamic outflow obstruction. Now, this is near and dear to my heart because in many ways it mimics hypertrophic cardiomyopathy. This occurs in patients with apical infarcts, and in order to maintain left ventricular stroke volume, basal contractile function becomes hyperdynamic. That can result in a dynamic outflow obstruction and hypotension. Well, why does that matter? Because in these patients, our treatment strategy is different. So you need to go and listen to the patient, and any patient who's hypotension after an MI deserves an echo. That's a reasonable thing to pursue. These patients, you want to reperfuse, but you're actually going to choose beta blockers to alleviate the hypotension. You're going to avoid the inotropes that you'll use in many of the other complications, and intra-aortic balloon pumps, which reduce afterload, will actually make the dynamic obstruction worse. So this is a very different treatment strategy, important to recognize this complication. Let's now shift gears and turn to the ruptured mechanical complications. Most ruptures occur within the first week and often within the first 24 hours following MI. And we'll go through each of these, starting with papillary muscle rupture. Papillary muscle rupture is an uncommon complication, but accounts for 5 to 10% of cardiogenic shock and occurs when the inflammatory response is going on in the heart, making the heart nice and mushy and ready to tear. The papillary muscles are a largely subendocardial structure, and so when you get epicardial coronary artery occlusion or narrowing, they are affected during subendocardial ischemia. The posteromedial papillary muscle is preferentially affected or most affected because in the majority of patients it has a single coronary blood supply, that of the PDA occurring from the right coronary artery in 70% of patients. The pathophysiology of papillary muscle rupture is that of acute severe mitral regurgitation. Left atrium is normally a low pressure chamber, but with the sudden jet of MR, you have a rapid rise in left atrial volume, a rapid increase in left atrial pressure, and flash pulmonary edema. The left ventricle, because it's ejecting the blood backwards into the LA, now has a decreased forward stroke volume, therefore a decreased cardiac output. And the body's natural response to that through baroreceptor response is to clamp down the blood vessels to increase the systemic vascular resistance in order to maintain end organ perfusion. However, that makes a higher afterload on the ventricle, and you get a vicious loop of higher afterload, more MR, worse stroke volume, higher afterload. So this is a spiral downwards hemodynamically. These patients present very sick, suddenly. Acute dyspnea and pulmonary edema, hypotension, and sometimes have a new systolic murmur, but sometimes don't. Can be quiet or inaudible. There's a rapid equalization of left atrial pressure between the LV and LA, and it can be almost like one chamber. With no pressure difference between the two, the murmur may be inaudible. It's a key thing to distinguish it from VSD. And diagnosis is readily apparent by echocardiography, and here we see that. This is a TEE performed at 0 degrees, and we can see the posterior papillary muscle, or the posterior mitral leaflet with papillary muscle attached, flinging back into the left atrium with each systolic beat, and there is torrential acute mitral regurgitation associated with this. No wonder the patient goes into pulmonary edema. Risk factors for poor outcome in this are advanced age, female sex, poor left ventricular systolic function, and diabetes, for whatever reason, is not a risk factor for papillary muscle rupture. I don't know why, but it's been shown. Treatment is urgent surgery. You may try and stabilize the patient while they're readying the OR with a balloon pump or with medical therapy. However, you need to operate on these patients or they will do poorly. Even the operation has high risk, 20% mortality, but if you don't operate, the ejection fraction suffers, as does long-term survival. And this is one of those scenarios, this is a race against the clock. The longer you wait, the more the end organ injury, the more the myocardial injury, the higher the rates of death. Let's next move on to septal defects. This is a rare mechanical complication that again has been reduced in the setting of reperfusion, tenfold. It occurs 3 to 5 days following infarct and can be within the first day. And there's some trials that have demonstrated increased incidence with fibrinolysis. This would be Gusto-1, the SHOCK trial. And here we see this on a basal short-axis transthoracic echocardiogram. You can see that there's disruption of the myocardium here at the inferior septum. And when we put color Doppler across this, there is a left-to-right shunt. This is associated with advanced age, female sex, and lack of collaterals in the distribution of the infarct-related artery. And that infarct artery can either be the LAD in about half of patients or an inferior infarct. Now, when we see the LAD distribution, this is a defect in the apical septum, and this is when you have a patient who has one of these wraparound left anterior descending coronary arteries, an LAD that supplies the whole apex. So when you block that off, the apex becomes completely ischemic, and they're prone to this. Whereas inferior MI occurs at the basal inferior posterior septum, and that's what we saw in the echo example that we just looked at. These patients do worse if they have associated RV infarct or RV dysfunction. And rupture occurs at the ischemic penumbrum, right at that border between normal healthy myocardium and the necrosis. These patients present with hypotension, shock, dyspnea, chest pain, and a harsh systolic murmur. They have a thrill and that helps to distinguish between it and acute myocardial infarction. And because these patients are less likely to have congestion, pulmonary congestion, we have the age-old adage that a new murmur with the patient lying flat is acute VSD, and a new murmur with the patient sitting bolt upright in pulmonary edema in acute mitral regurgitation is papillary muscle rupture. We see the left to right shunt of these patients that results in an acute rise in pulmonary flow, can have left ventricular volume overload, and a step up in oxygen at the ventricular level on right-sided cath. The shunt is larger when there's a larger hole. That's pretty intuitive. When it's harder for blood to leave the ventricle because there's an increased afterload. When it's easier for blood to go through the pulmonary circuit, or when left ventricular systolic function is worse. And that left me scratching my head at first. I didn't quite follow that one. But what happens is, if you have worse left ventricular systolic function, you have a reduced stroke volume, reduced cardiac output, and the body's natural response is to clamp down the blood vessels to maintain end organ perfusion. You get a rise in systemic vascular resistance, and look, we already said that that makes the shunt worse. These patients have a moderate rise in pulmonary artery pressure and pulmonary flow, and so they can have a V wave on their pulmonary capillary wedge pressure tracing, and that is not a good way to tell apart a VSD and an acute MR. You also get rises in right-sided filling pressures, particularly if there's an associated RV infarct. Initial treatment is inotropes, afterload reduction, balloon pumps, but this is really a Band-Aid because you need to get the patient to a surgeon. Even if they're hemodynamically stable, this can abruptly expand and result in hemodynamic collapse. Surgical mortality is high, particularly if there's cardiogenic shock, and mortality is higher in those inferior-basal VSDs like the one that we looked at. Let's next look at free wall rupture, and specifically frank rupture. This is an uncommon complication, but accounts for 1/4 of deaths post-MI, and typically occurs early, as with all the ruptures. This occurs in an elderly woman presenting with first myocardial infarction. An elderly woman presenting with first myocardial infarction. And here's a picture to drive it home. This is an elderly woman presenting with first myocardial infarction with free wall rupture. Risk factors include hypertension during the time when the ventricle is mushy, lack of antecedent angina, absence of collaterals because it's the first MI, use of corticosteroids or NSAIDs, and some studies would say delayed fibrinolysis. Others would say that this just moves up timing from presentation and it's not a risk factor. That's a little bit more controversial. Presentation, these patients present with acute collapse because they have sudden tamponade. And if you have PEA in a patient with first MI, you need to think about this. Sometimes there's an unheralded vasovagal event, and that should raise the hackles on the back of your neck. That may be your only sign before sudden death. Sometimes you don't get a sign. Sometimes they just present with sudden death. And most patients don't make it to the OR. But even if they do, mortality rates are very high. Let's next move on to contained rupture. So this is a pseudoaneurysm, and it accounts for about 1/3 of free wall ruptures. And instead of just pouring out blood into the pericardium, it's sealed with a little bit of thrombus or pericardium. And your only sign on this may be that you have a bit of fluid in the pericardium on echo, and so that should raise your suspicion. How does this compare to true aneurysm? Well, in these patients, you have just a little layer of pericardium, and so you don't have the broad base neck. Instead, you have a narrow neck that goes along with pseudoaneurysm, and it doesn't involve all layers of the myocardium within the aneurysm. Here we see an example. The LV is ruptured into this pouch here, and we see flow out into the pouch, both with color Doppler and with contrast imaging. These patients need to be operated on, and surgery is the treatment of choice because they may have unpredictable progression to free wall rupture that is not contained. We'll next shift gears here and talk about some of the electrical complications. And in my simplistic mind, these can be divided into things that go fast, either from the bottom of the heart or from the top of the heart, and things that go slow. So when we look at things that go fast from the bottom, ventricular arrhythmias are common in STEMI, but not all require intervention. Out-of-hospital arrest is often attributed to sustained VT or VF. And if you have a patient with VF or pulseless VT, get them out of it. You need to immediately defibrillate or cardiovert. And in these patients, you need to address, is there ongoing ischemia? Are there electrolyte abnormalities? Is there pump function dysfunction that I need to treat? But what about PVCs? Should we be suppressing those? Well, that's the question that was asked in the CAST trial. The CAST trial. Thanks, Dr. Ahman. So the CAST trial asked, should we suppress PVCs? And they were able to adequately suppress PVCs post-MI with class 1 agents. So these are sodium channel blocking agents. And what they found is that while they were able to suppress the PVCs, these patients had worse mortality. So we don't use those agents anymore, and we don't suppress PVCs. Electrical complications. So increased in PVC burden does not necessarily correspond with increased death risk. And so we don't specifically treat those in the acute phase of STEMI. However, if you get sustained VT after 48 hours after revascularization, this is associated with significant LV dysfunction and poor prognosis. And if there's not something that you can reverse, reversible ischemia, reinfarction, metabolic abnormalities, then these are patients that get an ICD during their index hospital stay. That should not be confused with patients who undergo primary prevention ICD. So it'll be discussed at length, but I just want to say it once here so that it's not confusing. But if you're putting it in because of a low ejection fraction, you need to give medical therapies time to work. You need to give the stunning time to resolve. And so we wait and reassess these patients 40 days after discharge. So these patients do not get an ICD during hospital stay. What about supraventricular arrhythmias, SVTs? Atrial fibrillation and SVTs occur frequently in the post-myocardial infarction setting, and I've given a number of reasons here why that could occur. Atrial fibrillation is the most common and can occur in about 1 in 5 STEMIs in some series. And it's higher or more frequent in the elderly, those with heart failure, and those with hypertension. We don't treat these patients with class 1 antiarrhythmics because we know that those have adverse effect on the basis of the CAST trial. And oftentimes these patients are met with a challenge of triple therapy. They may have just received a stent and are now on dual antiplatelet therapy, but now they have atrial fibrillation, high stroke risk, and may benefit from warfarin. And that can be a really difficult thing to deal with. Next, let's talk about the bradyarrhythmias. Sinus bradycardia is common following myocardial infarction, especially in inferior MI because of an increase in vagal tone. And in most of these patients, this can be observed. However, if patients become symptomatic or there's hemodynamically compromised, that's when you break out the atropine. And if atropine is ineffective, then we turn to temporary pacing. AV block and interventricular conduction delay is associated with infarctic stent. The more myocardium you knock out, the more conduction system you knock out. And particularly in inferior MIs, we tend to have more AV block, but this is usually transient. If you get a new bundle branch block, about a quarter of patients will end up developing a high-grade AV block. And thankfully, there's been a reduced incidence of conduction abnormalities in the setting of the reperfusion error. So the question arises, to pace or not to pace? Who do we give a temporary pacer to? So patients that go asystolic, those patients who have symptomatic bradycardia that's not responsive to atropine, those are people who we pace. When we get a Mobitz 2 or a 3rd degree AV block, we may consider pacing, but let's look and see, is this an inferior myocardial infarction? If it is, then we can oftentimes observe because they're transient. Whereas in anterior myocardial infarctions, this is a reason to put in a temporary pacer. When we get bilateral alternating bundle branch block, new bundle branch block with a 1st degree AV block or a trifascicular block, higher degree blocks here, then we're going to consider temporary pacing. When do we leave a permanent pacemaker in place? When there's persistent symptomatic secondary or 3rd degree AV block during that initial hospital stay, that's when I get my EP colleagues involved and ask for their help. And they've told me that there are some other things that can be reasons to put in a temporary pacer, and I've listed those here for your review because these are in the guidelines and would be testable, but those I'm not going to specifically elucidate at this time. Let's shift gears one last time and talk about non-myocardial complications in MI. We'll start with pericardial complications, and Dr. Amann has very nicely laid out findings of pericardial pathology in his lecture, but let's just specifically briefly talk about pericarditis in the setting of acute myocardial infarction. This, as well as many of the others, has a decreased incidence in the setting of the reperfusion era, and asymptomatic pericardial effusions are common, but they should raise your eyebrow. If you see a pericardial effusion after a new infarct, you should be thinking about a pseudoaneurysm contained rupture. You have to exclude that in these patients because it may be your only warning sign. Aspirin is the recommended treatment for pericarditis, and this is done at quite high doses. This is not a baby aspirin or a full dose aspirin. This is 600 milligrams every 6 hours, so very high dose aspirin. And in some patients, we consider other agents, particularly colchicine. Should avoid other nonsteroidals apart from aspirin and glucocorticoids. And there have been some studies that look at the role of colchicine in pericarditis. Now, these studies are not specific to acute myocardial infarction. In fact, most of these patients were idiopathic pericarditis. But the question was raised, does colchicine reduce rate of recurrence and recurrent hospital stays? And both the COPE and ICAP studies found that it does. So consider colchicine for acute pericarditis in the setting of acute myocardial infarction. Let's move on to our last category of complications, that of thromboembolic and bleeding. Patients who develop apical myocardial infarctions, particularly those with reduced ejection fraction, are prone to apical thrombus. You have stasis of flow here, and blood can form along an akinetic wall into a thrombus. These patients are at risk for systemic thromboembolism acutely, and presence of a new acute left ventricular thrombus in the setting of myocardial infarction is an indication for therapeutic anticoagulation. We've been talking about a lot of different medicines that thin the blood, antiplatelets, and these thrombolytics, all of these different agents. And anytime we increase bleeding risk is independently associated with a number of other complications, recurrent MI, stroke, death, longer hospital stay, and so it's always a balancing act, and you need to tailor therapies to your patients. We've been through an awful lot here. Let's go ahead and recap. I have 2 slides to help recap the approach to this, and then some clinical pearls to think about when you encounter these patients, either in the questions that come shortly thereafter, or on the boards, or in the wards. So in patients with acute myocardial infarction, it's important to have a framework to approach the complications. Complications can be mechanical, and those can be further divided into ruptured and unruptured complications. Unruptured complications include profound left ventricular failure, right ventricular infarction, LV aneurysm, ischemic mitral regurgitation, dynamic outflow tract obstruction. Whereas the rupture complications include papillary muscle rupture, septal rupture, and free wall rupture, which can either be frank or contained. Electrical complications can include tachyarrhythmias, such as ventricular arrhythmias or supraventricular arrhythmias, as well as bradyarrhythmias inclusive of conduction system disease. Non-myocardial complications can include pericardial, as well as thromboembolic and bleeding complications. So we've discussed more than a dozen very different complications that go along with MI, but you now have this framework to approach them and a lot of clinical pearls to consider for each of them. Let's just review a few really high-yield things for your boards. Avoid high-dose IV beta blockers in large acute myocardial infarction. Remember the COMMIT trial for that. In a younger patient with cardiogenic shock, consider early PCI and CABG. In right ventricular infarct manifest as low blood pressure, clear lungs, and elevated JBP, you're going to pursue reperfusion, but once the coronary has been opened, the first line is IV fluid resuscitation. True versus false aneurysms have a different appearance and involve either all layers of the myocardium or just that thin cap of thrombus or pericardium that's holding it in. Ruptures occur in the setting of an elderly woman presenting with first-time anterior myocardial infarction and may be present in the setting of delayed lytics. If you have a patient who's lying supine with a thrill, think VSD. Upright in pulmonary edema, think acute mitral regurgitation, maybe papillary muscle rupture. The pulmonary capillary wedge pressure V wave is not a good distinguishing feature. And in patients with VT following acute myocardial infarction, treat the ischemia, look for electrolytes, and then you may end up calling your smarter electrophysiology colleagues. I'll help you out with the echo. Let's go through the questions.
Go back to your list here, because there are actually some questions from the audience that we could hit at the same time. So somebody was confused because you said the COMMIT trial showed that beta blockers are terrible, yet there's a class 1 indication to give a beta blocker with myocardial infarction. Can you clarify that?
That's a really fantastic question. I think what the COMMIT trial shows us is that high-dose IV beta blockers given immediately following a myocardial infarction may result in hemodynamic instability. And when we think about these patients that are coming to our CCU with these large infarcts, our first reaction is now, oh, let's slam them with IV beta blockers. However, when patients can tolerate beta blockers, we should initiate them because we know that this results in better outcomes long-term.
Absolutely. So the 5 milligrams IV every 5 minutes that we used to do, followed by 50 every 6 hours, is out, but the oral beta blockers, once the patient's stable, is in. Another question about the cardiogenic shock actually is the European guidelines actually said intra-aortic balloon pumps are a class 3, yet the ACC says you can use them. What's your thought about an intra-aortic balloon pump?
You know, I think that this is an area that there's still question marks in. And in my thoughts, I don't turn to a balloon pump by default. I try and medically stabilize these patients, but if I'm struggling, it's something that I'm willing to take out and try. And there may be times when even that is not enough and you need to turn to the colleagues in the cath lab and think about even more mechanical support, particularly in unstable patients. So I think that I turn to these patients and I say, well, if medicines aren't getting the job done, then we have to keep going.
Yeah, I mean, if they're really unstable, there's our percutaneous devices that we can use, and the cath lab percutaneous pumps themselves, and probably an intra-aortic balloon pump in these people. I agree with ESC is probably outdated. It's never been shown to do much, except in mitral regurgitation, and really probably shouldn't be used. And like Jeff said, manage them medically, and if you have to do something, then take them to the cath lab and put an Impella device or something in them. Okay, let me see, what else? Oh, true versus false aneurysms. There was a question on the best imaging modality from an imager for that.
You know, I think that you can see true versus false aneurysms with things like cardiac MRI, but really the workhorse of imaging following acute myocardial infarction is going to be echo. And you can oftentimes see these very well with transthoracic echo. And echo can clue you into a number of these different complications, be it papillary muscle rupture, VSD, true aneurysm, false aneurysm, the left ventricular outflow tract obstruction. So it's really an extension of the physical examination, but the physical exam remains key, and oftentimes that alone is enough. You don't always have to wait for the echo to get there. You can trust your ears, you can trust your exam to tell you the difference between things.
And for the 3 people that asked about life vests following myocardial infarction, tomorrow we're going to have a whole session from the electrofiddlers, and they'll certainly talk to you about the utility of life vests in the patients that you're waiting to put a defibrillator in. Okay, let's go back to the questions then. So this 86-year-old woman with a history of hypertension has an inferior STEMI. She's pain-free. She has chest pain. On exam, she's in moderate distress, lying supine with a thrill, lying supine with a thrill, lying supine with a thrill. What's the etiology of her presentation? Oof.
Great. I think that's a round of applause.
I think that's a round of applause. Show us the initial one if you can. That was antiplatelets. Never mind. Okay, so let's go over this VSD, Jeff. From the practical standpoint, you've made your diagnosis. It's 12 hours later. What are you going to do?
You know, I think that we need to recognize that even if the patient is hemodynamically stable, this can acutely decompensate. And so this is the time when I would call a surgeon, bring them involved in the care, and think about that. There have been some very small trials that start to look at percutaneous interventions, and that may be a reasonable alternative in some patients, but I'm going to involve my surgeons and have them on board as we continue to manage the patient.
And you're going to want your surgeon on board right away. You know, we used to think that, we'll talk about papillary muscle rupture, and we would say, let's push the surgeon to do a VSD early, but if you've got an elderly woman, 86 years old, who's had an inferior VSD, they're very serpiginous, they're going to go into the annulus, they're going to be at very, very high risk as compared to an anterior VSD. So I wouldn't get upset with the surgeon if the surgeon said, let's hold off and see what happens, because even early operation by the best surgeon, the mortality with this type of person there is going to be 80% probably. So then it is really a big discussion with the patient and the family and the surgeon as to what actually they want. But sometimes pushing ahead with these type of patients might not be the best thing to do. And we have done device closures, but even device closures with an inferior, and that's the thing to remember. An inferior is going to be much, much more complicated than an anterior. You really have to think about what you're actually doing in the long term with these people. So that might not come up on a test, but you know that in your own practice you're going to get these type of things, and that's really weighing risks and benefits.
And it's about half of the VSDs as well.
Yeah, that's right. Look at the lift you had there. Okay, next one. Okay, 72-year-old man, 2 hours of crushing chest pain, ST segment elevation. He had a proximal right, excellent revascularization post-op. He's taken to the CCU, and in the CCU, he's got a tachycardia, hypotension. His venous pressure's elevated with X and Y descents, with X and Y descents, with X and Y descents. Next step in this management is IV fluid, IV furosemide, emergency echo, surgery consultation, IV dobutamine. Good. And do we have the pre? So how did you get people, the 34% of people to get much smarter there, who wanted to rule out tamponade and realize that this person has RV infarct?
Yeah, so examination is key. We said that the triad of hypotension, clear lungs, and elevated jugular venous pressure goes along with RV infarct, but as much of the audience recognize, it can look like other things too. It can look like tamponade, can look like constriction. But presence of the Y descent can clue us into the fact that this is not tamponade. This patient also has an S3, which would go along more with RV infarct, and that can really change how we approach management. Now, an echo would not be wrong to get on this patient to look for their hemodynamics to see how things are going, but that's not what the answer choice says. It says readying for pericardiocentesis, and so really the best answer choice here is IV fluids. Now, you might say, well, what about dobutamine? Couldn't we think about inotropes in a patient who has RV infarct? But much like one of the patients that Drs. Anna Vakar and Askew presented, this patient is tachycardic, and dobutamine in particular as a beta agonist may worsen that. We want to look for things like...
Although this one, though, you've revascularized. So I think this is a little different. What I was trying to get at before is if they are like that and they're not revascularized, you go for that. But you've already opened up her right, correct?
Yeah. And you know, the approach to this is going to be multifactorial. You're going to look and make sure that the patient is not hypoxic, because you could use supplemental oxygen. And depending on the hemodynamics and depending on your choices with your inotropes, you may end up looking into even further options and getting your surgeon involved in something like this, or your complex interventionalist.
Okay, let's go to question number 3. In regard to papillary muscle rupture, which one is correct? Anterolateral, IV phenylephrine, Harsh pansystolic murmur is typically present. Early surgical intervention, management of choice. Diabetes is a risk factor.
All right.
Very good.
Pretty good to start, pretty good to end. I think that's a great way to transition to dinner, perhaps.
They can't go to dinner yet.
Oh.
They have a sprint test.
Oh, all right.
But before you transition, there were a few questions. So this is papillary muscle rupture, in which you get the surgeon involved immediately. How about papillary muscle dysfunction and heart failure? You've got a patient in the CCU, inferior infarct, now has severe mitral regurgitation. But you look on the echo, and the reason to look on the echo is to see if it's a rupture. If it's a rupture, you go to surgery. What about if it's papillary muscle dysfunction?
So I think the first thing that comes to my mind is to correct ongoing ischemia if it's present. Remember, the papillary muscle is a subendocardial structure, and if you have residual subendocardial ischemia that's leading to that area becoming dysfunctional, that's the #1 thing I would go after to treat. You're going to try and optimize hemodynamics as well, and that's going to be important, but I would really make sure I tackle ischemia.
Absolutely. We've had a lot of people with high-grade circ lesions. You go in, you dilate the circ, the mitral regurgitation goes away. So that's ischemia. But what that then is and we'll talk about on Tuesday, there's a difference between primary mitral regurgitation and secondary mitral regurgitation. If you have primary mitral regurgitation, that's a disease of the valve, and as Jeff said, you go right away. If it's secondary mitral regurgitation, that's a disease of the ventricle. So before going in with a surgeon to try to correct the mitral valve, what you're going to do is everything you can for the ventricle, which is probably very aggressive medical therapy, looking at the ischemia, getting the patient out of trouble before you even consider anything in terms of surgery.
Might be one of the times when you would reach for a balloon pump.
Yeah, so that would be a time when you'd put a balloon pump in, let them try to recover and go from there, because you actually would like to reduce the afterload. Okay, well, let's give Dr. Geske a round of applause.